Hello everyone, it's me Dr. Muhammad Naseem Shirzad, and today I'm going to discuss one of the important topic of urology, and that is the angiomyolipoma. As you know that there are three malignant tumor of the kidney, that is the clear cell carcinoma, the papillary carcinoma, and the chromopope tumor. And there are two common benign tumor of the kidney, that is the angiomyolipoma and that is the oncocytoma. So now let's discuss the one of the common benign tumor of the kidney, and that is the angiomyolipoma. Angiomyolipoma initially described by Gravitz in 1900, and that's why the clear cell carcinoma or the renal cell carcinoma is also known as the Gravitz tumor because of this description by Gravitz. So it is a benign mesenchymal tumor. The angiomyolipoma is a benign mesenchymal tumor, and it can occur in two palm. Either it occur as a sporadically or it can occur as a part of tuberous sclerosis complex. And angiomyolipoma is actually belonging to a family of so-called picomas. Some picomas can behave aggressive and even metastasis, while the classical angiomyolipoma that is completely benign. So the angiomyolipoma is actually composed of three words: angiomyolipoma. Angio means the dysmorphic blood vessels, myo means smooth muscles, and lipoma mean adipose tissue. So angiomyolipoma is a combination of three words, and that is angio means dysmorphic blood vessels, the myo means the dysmorphic smooth muscle, and the lipoma means adipose tissue or pads. So because of this combination we call it angiomyolipoma. So as I have mentioned that angiomyolipoma, called the AML, it is present in two clinical settings. One is called sporadic, we also call it isolated angiomyolipoma, and it is the commonest one, means 80%. And the second is the syndromic, and it is 20%. The syndromic is the one which is associated with the tuberous sclerosis. This is tuberous sclerosis complex. So sporadic is present in 80% of cases. Sporadic is much of the time solitary, while the hereditary present in 20% of cases associated with tuberous sclerosis complex. And the hereditary tumor or the angiomyolipoma, which is associated with tuberous sclerosis, that are multiples and bilateral. Now the sporadic one, the growth rate of sporadic is that of 0.19 centimeter per year. That's why the sporadic type can be patient can be kept on the active surveillance, while on the other side the hereditary, the one which we call syndromic, or the one which we call that is associated with the tuberous sclerosis, that is 20%. The growth rate per year is 1.25 centimeter per year. So as compared to the sporadic type, the hereditary type having a higher growth rate. That's why much of the time we are treating these patients in the form of surgical intervention. So now let's discuss the tuberous sclerosis. As we have mentioned that it is one of the well described heritable cause of angiomyolipoma in 20% of cases, and these tumors are often bilateral and multiple. The genetic of this disease is important. Tuberous sclerosis is autosomal dominant disease, and it arises because of the mutation in either tuberous sclerosis 1, which is encoding hamartine on chromosome 9, or the mutation in tuberous sclerosis complex 2, which is encoding tuberine, which is located on chromosome 16. Normally what happens that the hamartine and tuberine normally inhibit mTOR, and mTOR is a mammalian target of ripamycin, and normally the function of mTOR is to cause cellular growth and angiogenesis. But this angiogenesis and cellular growth is inhibited by the hamartine and tuberine, as hamartine and tuberine inhibit mTOR. But when there is a mutation in hemartin and tuberin, so there is no inhibition of the mTOR, but the mTOR is upregulated and uncontrolled, and that's leading to uncontrolled cellular growth and angiogenesis. So the discussion on this whole genetic makeup was important, as we know that the medical treatment of the angiomyolipoma in case of tuberous sclerosis is based on this genetics. You know that everolimus, which is mTOR inhibitor, it has shown 30% reduction in 80% of the patient in phase 3 trial. So it is now the only approved medication for the treatment of angiomyolipoma, and the mechanism of action is based on this mTOR inhibitor. So now as tuberous sclerosis is a syndrome, and it can involve multiple organ, like it can cause hematoma in the CNS and can cause in the retina, and it can also cause facial angiofibroma or adenoma sebecum. In the heart, it can cause mitral regurgitation, and it can also cause rhabdomyoma. And it can also cause mental retardation, and the intellectual disability can also cause seizure. So that's why when these patients present with angiomyolipoma, we must going for the MRI brain to exclude these tumor in the brain. Now, what's the clinical presentation of angiomyolipoma? Clinically, angiomyolipoma much of the time is diagnosed or found incidentally. Around 80% of the patient is diagnosed incidentally by performing ultrasound from some other reason. And other patient can be presented with the flank pain or visible hematuria or palpable mass, and many of the patient can present with the retroperitoneal bleeding, which is called the Wunderlich syndrome. So we will discuss the Wunderlich syndrome in detail. So Wunderlich syndrome, the 15% of the patient of angiolipoma can present with the retroperitoneal bleeding, which is actually emergency. So this is one of the presentation of the angiolipoma, and it is the acute onset of the spontaneous renal hemorrhage into the subcapsular or perirenal or pararenal spaces. And the reason behind this bleeding is when the tumor angiolipoma is more than 4 centimeter in diameter, that can develop micro and macro aneurysm, and that micro and macro aneurysm can lead to spontaneous rupture. So this is the pathophysiology behind this Wunderlich syndrome, and it is classically characterized by a triad which is called Lang triad. So the Lang triad is composed of acute flank pain, flank mass, and hypovolemic shock. And this Wunderlich syndrome is treated depending on the condition of the patient. If the patient is hemodynamically stable, we can treat the patient with angioembolization, emergency angioembolization, or in some cases nephrectomy may be required. Now let's discuss the investigation for AML. As we have mentioned that AML in a half of the cases diagnosed incidentally by doing the ultrasound for some other reason, but the finding ultrasound is showing that it is eco bright pattern as PET or reflect the ultrasound wave. That's why there is no aquestic shadow in the case of AML, while there will be aquestic shadow in case of calculus. That's why in ultrasound both stone and AML appear bright, but the difference from stone or calculus is that there is no aquestic shadow in AML, while there is a aquestic shadow in case of calculus. Now let's discuss the CT scan. So the MRI and CT scan is the diagnostic for AML, and on CT scan what we are looking for Hornsfield unit, and the Hornsfield unit in case of angiomyolipoma is in minus, and the reason of this minus is that as it contains PETs, that's why it's giving us minus Hornsfield unit. So it's giving usually minus 15 to minus 20 Hornsfield unit. So one other important things, and that is the immunohistochemical stain, and that's immunohistochemical stain, which is called the HMB45 marker. And this HMB45 marker is used when you have a doubt that is it RCC or is it AML. So it can differentiate us as the HMB45 is positive in AML and it is negative in RCC. But it's also important to understand that HMB45 is also positive in metastatic melanoma. So HMB45 positive in angiomyolipoma plus metastatic melanoma, and it is negative in RCC. Now, as we have discussed the diagnosis, now coming to the management. Once you made the diagnosis, the management of the angiomyolipoma consists of four treatment options. One is active surveillance, the other is the medical treatment, the other is the intervention like angioembolization, and the fourth is the surgical treatment. Active surveillance is the most appropriate option for most of the AML and 48% of cases. So, as I mentioned, that active surveillance is considered a first line option for most of the angiomyolipoma, and the cutoff for keeping the patient on active surveillance is 4 centimeter. But it should to be kept in mind that only this 4 centimeter is not important to keep a patient on active surveillance, although this is one of the cutoff point for keeping the patient on active surveillance. But other factors should to be kept in mind, which can help us in the to keep the patient on active surveillance or to go for the surgery. For example, if a patient having more than 4 centimeter tumor or having less than 4 centimeter tumor, but it is having a high risk of bleeding in pregnant women because this tumor is positive for estrogen and progesterone. That's why the risk of bleeding in female patient is high. That's why active surveillance is not a good option in pregnant women and childbearing women, and it is also not a good option in a patient who are at high risk of abdominal trauma, like they having a job where there is a risk of abdominal trauma. So we can't keep that patient on active surveillance. We can't keep the female of childbearing age or a patient who follow up or access to the emergency care may be inadequate. For example, if a patient is living in far-flung area, so it will be very difficult to come for that patient to follow up in the clinic. The medical treatment of the angiomyolipoma, as we have noted earlier, that tuberous sclerosis is associated with mutation that result in the activation of the mTOR pathway. So any medication that leading to the inhibition of this pathway will be helping in the management of angiomyolipoma. So currently the everolimus is approved by the FDA and is used in a setting where the tumor is very large or multifocal in patient with tuberous sclerosis. The surgical option in case of bilateral angiomyolipoma, when the tumor size is more than 4 centimeter or the patient don't want to be kept on the surveillance, or the patient living in far-flung area, or the patient at risk of bleeding like pregnant women or female of childbearing age. So these patients can be optioned for partial nephrectomy. So now let's discuss the selective angioembolization, and this is the first line therapy in a patient who present with active or potentially life-threatening hemorrhage, like in case of Wanderlei syndrome where the patient is actively bleeding. So in that patient, the first line should be a selective embolization, as the exploration in such a patient and in such a setting is often associated with total nephrectomy. So because of this risk of total nephrectomy and exploration, better to go for the angioembolization. And in second condition, like if you just want to select the angioembolization as the therapeutic option for angiomyolipoma, even in non-bleeding condition, it's also a good option. But the problem with this selective angioembolization, again, that the patient need to be kept on active surveillance in spite of this selective angioembolization, and because of the recurrence.